Good afternoon. My name is Hyuk from Seoul National University Hospital in Korea. On behalf of our team, I'm honored to present pure robotic living donor liver transplantation, expanding minimally invasive possibilities in liver transplant surgery. This presentation highlights the case of purely robotic LDLT, including both explant hepatectomy and graft implantation. In presentation, in relation to this presentation, I declare that there are no conflicts of interest. Liver transplantation remains the only curative option for end-stage liver disease. While open LT has long been standard, minimally invasive approaches are being cautiously introduced. Robotic platforms offer a viable alternative, especially in addressing limitations of laparoscopy. Laparoscopic liver surgery is limited by restricted maneuverability, lack of wristed instruments, especially for anastomosis, poor visualization in highlight area, and steep learning curve. Robotic surgery has overcome these barriers through 3D magnified vision, articulated instruments for better control, replication of open techniques within a closed field, and improved cosmesis and reduced morbidity. Our recipient was a 47-year-old male with HBV and prior TACE. His plan is ABO incompatible LDLT with rituximab and plasmapheresis. The right graft was used, and his childhood score was 5A. The donor was a recipient's 19-year-old daughter. Her future liver remnant is 35%, and GRWL was 1.33. No significant stenosis was observed. Anatomically, she had a preserved 8 millimeter right inferior hepatic vein and an extrahepatic bifurcation of the right hepatic artery. Now let's move into the surgical video. We begin with the robotic mobilization and explant hepatectomy using the Da Vinci platform. First, we begin with complete liver mobilization. After mobilization, cholecystectomy is performed. We proceed with highlight dissection. First is encircling the proper hepatic artery and common bile duct. Next, ligation of the left hepatic artery and left bile duct. Now, the ligation of the right hepatic duct and right hepatic artery. Next, the right portal vein is divided and main portal vein is encircled. And then further mobilization. Right hepatic vein is divided using a stapling device. The main portal vein is divided. Then, both the left hepatic vein and middle hepatic vein are divided simultaneously with a stapling device. And the recipient liver is extracted via a funnel stain incision using a hand assist approach. And next video is graft implantation. The graft is implanted through the same funnel TL incision. The IVC is totally clamped with 2 scheduled clamps. Right hepatic vein and right inferior hepatic vein were anastomosed. Next, we perform portal vein anastomosis with continuous suture, followed by reperfusion. Doppler ultrasonography is used to assess flow. And the graft right hepatic artery is anastomosed to the recipient right hepatic artery. Finally, viaduct reconstruction is performed. Multiple anti-bleeding agents are applied, and final Doppler reassessment is needed. The total operation time was 9 hours and 45 minutes. The explant hepatectomy took 4 hours. The warm ischemic time was 58 minutes, which we consider acceptable given the fully robotic setting. On the right side of the slide, you can see the port placement strategy. We used the funnel stain incision for hand-assisted port. Postoperatively, the patient had an uneventful and stable recovery. On postoperative day 1, liver Doppler ultrasonography confirmed good arterial and portal flow as shown in the images on the left. By postoperative day 4, contrast-enhanced CT imaging demonstrate excellent vascular and biliary patency without signs of thrombosis or leak. Most notably, on postoperative day 5, both the patient and the donor were discharged together without any complications. This rapid recovery reflects not only the patient's preoperative condition, but also the potential benefits of minimally invasive robotic surgery, including reduced trauma, early ambulation, and faster return to baseline activity. In conclusion, our case demonstrates the robotic-assisted living donor liver transplantation is not only technically feasible, but also safe and reproducible in selected patients. This approach has several potential benefits. It allows for reduced intraoperative trauma, earlier ambulation and discharge, as you saw in our case, and significantly improves ergonomics for the surgical team during long and complex procedures. On the left side of the slide, you can see the recipient wound appearance on postoperative day 5 and again at 3 months, showing the minimal scarring. On the right, this is a video of recipient working out after discharge. We believe that this approach represents a meaningful step forward in minimally invasive transplant surgery. Thank you for your attention.